for being here. It's a pleasure to see everybody and to see this event grow each time we host. So this is our 4th edition of Coffee and Collaboration. And for those of you that are new to this event, it's an event that takes place. We try to organize bi-monthly, so every other month, as a way to share and foster collaboration between clinical and research teams here at the Douglas. And for those that don't know me, my name is Kelsey, and I'm the clinical coordinator at the Center of Excellence in Youth Mental Health. So as I mentioned, the vision behind this event was to create a collaborative space where research and clinical teams can openly share knowledge, spark new ideas, and bridge the gap between science and practice. For the next event, it'll be taking place on June 18th, hopefully in a much bigger space. I will send the invites out to everybody, and I would really appreciate it if everyone can actually RSVP to the calendar event. It really helps in terms of ordering food and making sure we have a big enough space to accommodate everyone. For those of you that can't attend the event in person, it's also a hybrid event, so we have attendees on Zoom. And now with the help of Aha, who's our communications coordinator, all of the events are recorded and available online on our CEYMH YouTube channel. So once the event is finished, you can share the link with anybody in the network who you think might benefit from these talks. So today I have the pleasure of welcoming 3 speakers. So we have Fiona Meister, who's a PhD candidate here at CEYMH. We also have Lani, who's a PhD candidate in the Mallar Chakravarty lab. We also have Dr. Booij, who's a PhD and clinician in the eating disorders continuum here at the Douglas.
Thanks again for being here. It's the most crowded event. And just a disclaimer before I start, this is a brand new presentation. I just finished my slide this morning, so I apologize in advance if anything. But before we begin, before I even tell you what my presentation is about, I'd like to show you a quick video. So this is a bit hard to watch, but that was the reality of some of the patients and the 40s, on the 40s. So this shows a psychiatric patient with very strong muscle rigidity. And fortunately nowadays, with medication like lorazepam, this can resolve in as little as a few minutes. So this didn't happen magically. This happened because of concerted efforts between clinicians and researchers. So that's what my presentation is about today. So today I want to talk about the importance of research in clinical settings. So I won't present like specific results, but more about the relevance of research. And so what is the point of this presentation? Because that would seem like logical, but actually it's not. Because sometimes we kind of feel that like researcher and actual clinicians are on different planets, having different goals, speaking different language. So I think it's important to maybe explicit why we're actually doing the same thing. So to do that, I will tell you a little love story. Oh, so sorry, my animation didn't work. That's what I was fearing. But anyway, so we have Harry here, and Harry is very happy because he recently met a new girl with all of Sydney, and he asked her on a date, and she said yes. So far, so good. Harry is very happy. However, he remembers that 6 months ago he had a date with Kim, and it didn't go that well. So now he can't stop thinking about it, and he's getting like really anxious, and he's really afraid to mess up this new date. So that doesn't work again, but anyway. So Harry has 3 options. So the first one is to get like basic advice from his friends. The second option is to look at WikiHow or other online advices, or to go see an actual psychiatrist. And since Harry is a smart guy, that's actually what he does. So why is seeing an actual psychiatrist a better option than these two? So because this doctor, will give you an actual diagnosis and hopefully a treatment plan. And again, what makes it better than other solution? It's because it's backed by clinical practice and research. But what is actually clinical research? What does it mean? So here I provided the official definition from the Canadian government. So I will quickly read it. So it's clinical research is a branch of healthcare science that involves human participants to evaluate the safety and effectiveness of new medication, medical devices, diagnostic tools, and treatments. It seeks to improve patient care by translating laboratory discoveries into actual medical practices. So still, this is a bit confusing. So I will try to simplify it more. Basically, it's a bridge to translate theoretical knowledge into clinical application. And how do we bridge these two things? What do we do in our research project? So this is very simplified, but basically it's like this, and I will exemplify it for the Mo project and our friend Harry. So first, we have a question. So we can wonder, for example, in the Mo project, can speech predict relapses in psychosis? Or in the case of Harry, what medication is the most effective to reduce anxiety? So then we formulate the hypothesis about those questions. So it would be yes, we find that we can predict relapses of speech, or that Xanax is the most effective at reducing anxiety. I don't know, I'm not a doctor, so I don't know if it's but then we need to test our hypothesis. So we collect data. So for Mo Plus, we're collecting patients with a first episode psychosis at PEP, but it could also measure anxiety level in people that use Xanax versus those that do not use Xanax. And then, as I said, we do like fancy statistics and we test our hypothesis, and hopefully we can publish our results or disseminate it in other way through conferences or other scientific communication. And then the next step is implementation. So, for example, we could design an app that could warn clinicians if a patient is at risk of a relapse, and we can prescribe Xanax, which is proven to be the most effective for Harry. So, why research is needed in clinical settings? So there's multiple reasons. So this is not exhaustive, but first of all, it's to move beyond intuition. It's to get actual data. So this intervention worked for this patient, but is it what generally work for most of the patients? And then if we know that, then we can know if we can apply it to a specific person. So in case it's Harry. It's also to introduce novelty. So, for example, developing new tools, for example, the sofa that we know about functioning, new medication, and new intervention like your support workers. So should we keep Mark Andre's salary or not? That's what research can do. Then it's also it also offers tools to quantify what we cannot quantify. So how to measure anxiety, that's intangible. So through research, we can develop actual measures to quantify this. And then we can ask further questions. So does Harry's level of anxiety decreases over time? And on the other hand, why do researchers need clinicians? So first of all, something very pragmatic, it's to help us with recruitment, because we need to collect data. Without data, there's no research. And clinicians are usually the first point of contact between the researcher and the potential participants. So they can introduce us and also explain potential research projects. Also, that's a cliche that has la vie dure, is that researchers sometimes are a bit in their bubble and they're not always aware of patients' reality. And I'm not gonna lie, sometimes that's the case, and we're a bit obsessed with our results. So by interacting with clinicians and getting feedback from them, we're confronted to the reality of a patient and what is actually needed. Is my research question, my aim, important, or is it just a waste of time? And then, of course, the translation of the findings, because doing research for the sake of doing research is pretty pointless, but then we need to apply our findings in actual clinical settings. All right, so remember my first slide. So I hope that now I've managed to demonstrate that we actually need each other. And thanks to both researcher and clinician here in Sydney got married. And that was supposed to look cooler because they were supposed to appear after. But anyway. All right, so beside this successful love story, here are other things that we've all achieved as the medical community. So, for example, reduce average hospitalization time. So, at the beginning of the 20th century, it was more than 2 years. And then it went down, but it's still long, to around a month in the beginning of the 80s. And I even found a paper from the 80s where the average hospitalization time for a patient with psychosis was 22 years. And nowadays, of course, it depends, but it's around 9 days. And even though it was older data, so maybe now it's even less. We've greatly improved symptom management and prognosis. So we don't have direct data to compare, but again, like first half of the 20th century, only 34% of patients could actually return living in the community after a first hospitalization for psychosis. And nowadays we have 54% symptom remission in first episode psychosis. So that's far from being perfect, but that's already a huge improvement. And we're also moving toward destigmatization and valorization of lived experience. So we used to be in a situation where psychiatric patients were systematically excluded from society and physically put away, like we can see the Douglas, for example, which still nowadays is still away from the city center. And then we started having advocacy groups, and I thought the name very funny, College Lunatics Friends Society. And then still we had improvements, but patients were still excluded from clinical and research settings. And now we're getting there, it's getting a bit better because we're moving toward including lived experience in both research and in clinical teams. Before I go to the next slide, I'd just like to say, of course, it's not perfect. For example, negative symptoms are still poorly understood and they're still not well addressed by current medication. And also, for example, for stigmatization, we have like reduced stigmatization towards, let's say, depression, but there's some data that show an increase in stigmatization toward psychotic and personality disorders. So these are all issues we still need to work on. So how can we effectively collaborate to drive future changes together, so researchers and clinicians? So for clinician, the most important is refer participants. Please, 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 that's, you can't imagine how important that is. Also, please feel free to communicate your needs and questions. So if you're like, oh, like I was wondering if that was effective or what does that mean? Like, of course, we can't guarantee that we can answer it, but it's a good way to like calibrate like our research objective or what needs to be addressed. And also, if you're like, oh, you're doing this research project, but why are you doing that? Like, how is it applicable to me or my patients? Like, please feel free to ask. This is always important. And on the researcher side, we're trying to do, and we should do our best to minimize the burden for clinicians. So we don't want to increase your workload. So we're trying to find ways to communicate more effectively, etc. And also, I think something that's often forgotten but is really important is translate our findings into accessible language, because sometimes we disseminate our results in, let's say, scientific article, but we're usually the only person that understands it. So we need to be able to explain how our research can be actually applied in practice. And of course, we're both of us attending events like this one. All right, so that was it for me. So thank you so much, and please don't forget my.
Like 2 minutes. If there's any questions, there's a couple of minutes for the Fiona to answer some questions.
Not so much a question, it's just, I really, really appreciate this, because I think it's the basis of why I'm doing, these funding collaborations, so it is, to get to know each other better, and exactly find ways of working more closely together, so thank you, it was a very good presentation.
Thank you. Yeah. Perfect, thank you, Alvin.
Yeah, I might have one small question, but necessarily reducing the amount spent hospitalized might not be good. It might also be like, oh, we have less money or less care to
I
do,
was
so we're gonna
expect-
keep them up.
I was expecting that part, but it's another.
Cool. Thank you all. Thanks, Fiona. That was like such an awesome presentation to kind of lay the foundation. I'll provide kind of an example of a project. We're trying to effectively do just what you're highlighting and incorporate lived experience into like a research project. Yeah, some of you might have seen a little bit about this presentation before from Mallar, so I'm sorry if it's a little repetitive, but I'm going to focus a bit on a different angle. So I'm a co-applicant on a grant that was recently funded by the Wellcome Trust called YUCCA, Youth in Urban Centers Across the Americas, Understanding and Addressing Heat Impacts on Mental Health. And today I'm specifically going to talk a little bit more about how we've really worked hard to incorporate community voices and lived experience into the design of this project and some of our plans for moving forward, how we hope to continue to do so. So our project takes place over 3 different locations. Here, Montreal, which will, all of the participant recruitment will happen here at the Douglas, in Querétaro, Mexico, and in Buenos Aires, Argentina. And we have a fairly diverse group of researchers that are leading this study. The lead PI, Yura Augustinavicius, is at UDM, and she specializes in public health. Specifically, her work looks at climate change and mental health outcomes. And so in this study, we're really looking at heat exposure, how heat exposure impacts mental health, and trying to understand what mechanisms connect those 2 ideas. Because we have a lot of evidence that exposure to heat does negatively impact mental health, but we really don't know very much about how exactly that happens. And if we want to develop interventions that can help that path, then we have to understand that as well. Mallar and I are neuroscientists. We also have an environmental epidemiologist based in the States. Then we have project leads. Carolina Abulafia is in Buenos Aires, and she's a psychologist and studies sleep. Eduardo Garza de la Real is in Querétaro, and he's another neuroscientist with MRI expertise, which we have as well. And then Guido Simonelli is also based at UDM, but from Argentina, so another link there. which is kind of how we came across these 3 study locations. So the major goal of this study is to examine the relationship between heat and mental health among urban youth who may benefit from care for depression, anxiety, and psychosis across different sites in the Americas, and to understand the mechanisms that drive those relationships. And then the final piece is really to integrate some solutions into existing mental health care. So I'll just spend a little bit of time talking about our what actually constitutes this project, and then focus on again the lived experience piece. But effectively, what we're doing is developing cohorts of youth and young adults. We have quite a broad age range, 16 to 35, so a bit generous with the young adult, but of people who have low-level symptomatology of anxiety, depression, or subthreshold psychosis symptoms. So the bulk of the cohort, the full cohort, will do online assessments bi-weekly over 2 years and be compensated for that, but be able to do this study effectively fully remotely. And then we'll get the heat exposure from 2 different sources. So from the full cohort, we're going to reanalyze existing satellite data where we can extract heat exposure. But we also have a sub-cohort where we're going to ask them to have an indoor temperature monitor, which they'll keep on their bedside table, so that we can have, first of all, an understanding of how the analysis from the satellite data relates to actual exposure, but then also an indoor temperature source. And then we'll also recruit a sub-cohort from the full cohort who's interested in having a wearable device. So right now we're looking at the Actigraph Leap, which can record not only physical activity, sleep measures, but also you can calculate an estimate of core temperature. So that's important to understand how thermoregulation may impact the temperature someone experiences compared to the outdoor temperature. And then a further sub-cohort will be recruited to do MRI as well, so that we can start to understand whether there's any brain changes that are underlying this association between the heat exposure and the mental health outcomes. One of the major aims of interest, I think, here is that we want to co-design an intervention once we understand what mechanisms are associating these two. And I'll talk a lot more about that aim later. And then briefly, I wanted to mention too that we have another aim on open science, so making sure that the data can be appropriately privatized, but then also shared for other research analysis that can happen, and really make use of this data beyond the extent of the way we're collecting it. Yeah. So there's been 3 major ways we've conceptualized integrating lived experience, and I'll go into each of them, but we've incorporated some into the project development, which is really thanks to the work that you all are doing. Yeah, like meeting with the councils wouldn't have been possible without the infrastructure that you all already set up. And I definitely attribute the awarding of this grant in large part to the fact that we were able to engage in that way. We also want to make sure that there's representation in project leadership and design throughout the study, and then the implementation of project activities, especially with that second aim. So more specifically, we presented for the CEYMH Youth Councils here in Montreal, as I mentioned. And then we also discussed the grant with lived experience experts in Argentina, and we're developing those relationships in Mexico, which were not at the time pre-existing. And then one of the organizers of the councils also agreed to be a collaborator on the grant, and she read all of the materials to make sure that we had properly integrated the advice that was given to us by the councils into like the grant proposal. And for the project leadership, here's kind of our proposed structure. So we'll have this steering committee in the middle, which is like all of us co-applicants, but then also a lived experience expert from each site. And we're going to be meeting monthly over the course of the study to really make sure that it's in line with the grant proposal and in line with like the needs that we've heard and things that are coming up. We have a study advisory board who has both technical expertise, but also another lived experience that's the collaborator on the grant. And then we have 3 community advisory boards, 1 at each site. So these will be people who would fit the study demographics exactly, but who will meet twice a year over the course of the planning and collection and analysis to help continue to give feedback and interpret some of the things that are coming up in the grant proposal. Oh yeah, and then for the other major place where we're having lived experience come to play is the intervention co-design. So as we've oh here, I think this will be useful. So here's like kind of a messy diagram, but it's all the ways we think heat exposure can impact mental health and all the different mechanisms that we'll be able to start to look at with the data that we're collecting. So if we find, for example, that sleep is really a big driver in our models of how heat is impacting mental health, then we can help use this to guide some of the co-design process and say like, okay, we know that sleep is a huge important factor, that when it's really hot, people don't sleep well, and that impacts how they're feeling. So we want to design an intervention that can perhaps target sleep hygiene. And so we're going to engage in expert consultations with people who have expertise in that specific field, and then co-lead design workshops with youth with lived experience both here and in Argentina, because there could be site or cultural specific factors that could impact that intervention. And the way that we are conceptualizing this right now is for the younger youth, we hope to do kind of a summer camp style workshops. And for older youth who might be working, do a couple of weekend sessions. And from that, we can develop a prototype of an intervention that we can pilot and then ideally integrate into existing mental health care. So that it's not something that is kind of tacked on additionally or like a huge extra burden that people are undertaking, but it's something that can be integrated directly into what they're already engaging in. And so it's still a little vague right now because we don't yet know what mechanism we're going to target, and because it is by definition something that would be co-design. But I think that's going to be a place where it's really important that we have this close collaboration with the research, the data that we're seeing from that, but then also what actually is important to people and what they actually think is going to be useful in that regard. And I think tied in exactly to what Fiona was saying at the end, we really care about impact beyond just the publications, which are like so precious in scientific research. So I mentioned we have this kind of open and secure data set aim where we think that this is going to be such a rich data set and it'll have a lot of utility beyond what we even imagine right now. The co-designed intervention, we're going to document all parts of that process, so not just what actually comes out at the end as the intervention, but also how the co-design sessions were run, how they worked, what we learned along that process, so that other people can also kind of adopt a similar approach. And then I think that there also could be some potential for like policy briefs or recommendations. Again, if we understand that like one of the major problems is that people don't have a place to congregate that's cool on really hot days or during heat waves, and that's something that drives social isolation and that contributes to negative mental health outcomes, then we can make those kinds of recommendations to our local governments or more broadly, and hope that they can kind of act on that directly. So we haven't even received money yet. It's starting in June. So we're still very early in kind of the project planning phase. And so that's why I was excited to speak with you all today as well, because that means that effectively we can still steer this ship. We have lots of like room for your input, but it's a 5-year grant. So it'll be kind of running until 2030, 2031. So I'm sure that you'll also hear from us again kind of throughout that process. Yeah, but for now, I'd just like to thank everyone who made it happen up to now, and we really look forward to seeing where this will take us.
Yeah. Well, thank you so much for the invitation to present today. So on paper, actually, I wear 2 different hats. I work as a clinician, I work as a researcher, both in even sort of program. And I'm just going to share you some of the perspective I have as a clinician researcher, rather than going into specific frameworks or results. So I'm basically in Zurich's Continuum. So it's one of these 2 buildings that's close to Booij South. You see here our outpatient program, where also we have a research space and we have our inpatient unit, our day program on the building on the rates. So just a bit of background on the program. So we're the only specialized program for adults of the scale in Quebec. we have a supra-regional mandate, which means that technically speaking, referrals can come from everywhere across the province. Although in reality, we don't often get patients from very remote regions until it's like really severe. The basic principles of the program is we have an evidence-informed approach. So the clinical practice is based on science, so this is demonstrated science. Multidisciplinarity, we work with a stepped care model, which I explain next slide. And also an important mandate is to really think about not only care, but also research and teaching. And I get to that as well today. So here you see basically our clinical program. So what happens if someone looks treatment for eating disorder in our program? So when we get the referral, we triage them. They often have to wait a bit until the treatment. And then once their turn, basically we have 3 levels of care, which is called as well, we call the step care model. The biggest box there is that our outpatient program, approximately 300 patients per year we follow. Day program is there in the middle, which is 4 days a week. And we have a small inpatient unit as well, if it's absolutely needed. Most of our patients follow outpatient treatments, which is individual therapy, usually a group, and if needed as well, consultations with a psychiatrist, a nurse practitioner, or a nutritionist, or all of them. And basically, the intensity of treatments could change according to the patient needs. So they can basically step up or step down, which is why I refer to a step care model. Our treatments are limited in time, so they're not in treatment for years generally. But there's always the possibility as well to come back later on if treatments are needed, because we do know eating disorders sometimes can be really strong and people could get back as well to relapse. We also work a lot with primary care. I get to that as well in a minute, but we train health professionals in the community to be able to better help with dealing with eating disorders. And also we work closely with community organizations, in particularly Anorexia Bulimia Quebec, ANEP, which is a very important resource have all kinds of resources for people with eating disorders and their families. So the clinical realities of the program, and as well just the current realities of the healthcare system, along with the science of eating disorder, basically set the pillars of our research program. So briefly speaking, the reality is that we know actually still very little about eating disorders. I always say in terms, for example, the neurobiology, we're 20 years behind compared to certain other psychiatric disorders. We know that biological, psychological, and social factors plays a role, but there's a lot of things to figure out. We also know from data from our own program, as well as from what's published out there, that eating disorders are often treatable. But surprisingly, we still don't know exactly what predicts an outcome. But we do know that people recover often in different ways, not in the same way, and definitely not at the same rate. In the community, there's often still a lot of misunderstandings about eating disorders. There's a lot of stigma in the population, but also in people who may not have all the expertise, certain educators or certain clinicians outside the field. And the healthcare realities as well is that treatment options are limited. Also given, as I said, there's not much adult services or eating disorder services in general in Quebec or even in the country. So based on that, our research program was inspired by these clinical realities, and basically can be organized in 4 themes. One research theme is focused on neurobiology, one on predictors of clinical response. We do some work on self-help for people who are on the wait list, and we also have trainings that we offer to first-line services and also evaluate them with the goal to make them better. I'm going to present you very briefly the themes, but again, I'm not going into specific results, but feel free to ask questions afterwards. So in terms of neurobiology, we do some work on genetics and epigenetics. So epigenetics means how basically environment could impact the activity of your gene and how social and psychological factors interact with biology. We have a large-scale neuroimaging study in place. The name is ANIMATE. ANIMATE stands for Anorexia Nervosa Imaging Study in Adults and Teens. And it's a national study. We're leading it and we work closely as well with sites across the country. Most of the work is actually, most of the data collection takes place at the Douglas, but also other sites as well are actively collaborating. The second theme of research we called is predictors of response. For the animate, for the other slide that I presented here, most of our patients that are recruited in the Douglas come from our program. And basically how we manage recruitment is in our team meeting, when new patients are being discussed, we also then look already at that stage who could be eligible to participate in, for example, the ANIMATE study. I get to that as well, recruitment a little later. So predictors of response. So we have a measurement-based approach, which basically means that before patients come for an evaluation to start treatment in our program, we send them, the secretary send them questionnaires. These are for clinical purposes, but there also is a box to tick if people are accepting that we can use them for research. If that's the case, they end up in an anonymized database that can be used for research. If they don't want to do that, for sure, we still offer treatments. They just don't end up in this research database. There is also some clinical ratings to do through a standardized form that has some questions around eating disorders. And then we keep doing all these questionnaires approximately every 4 months until file closure, or if people change in treatment intensity. So that means, let's say someone is an outpatient program, they go to day program, then we offer them a new set of questionnaires. And then when they step down, we do that again, and then up to their file closure. We have used this data. This is not a new system. This has been in place as well a long time, started by my colleague Howard Steger. And we have published over the years various studies using this database. I'm presenting you just like one study that we used for that. We know from just general knowledge that a common myth is like the longer someone has an eating disorder, the less likely the person would recover. And this is often what we also hear from our patients. I've heard as well as a clinician, sometimes patients say like, it's nice what you offer, but I'm not sure if I can recover because I already have an eating disorder for 15 years. And also around clinicians can be also like some sort of, not sure if that of like duration of illness will play a role. So when this question came up, and this question was actually really born during, I think, peer supervision meetings in our clinical team, that we really want to know, is it really the case? Like, does duration of illness, does that tell you something, how someone will respond to treatment? So when we looked into the literature, it was a bit of a yes-no story. It was very inconsistent. But there were not in the literature, in the research, many cases that had a long history of illness duration, like longer than 10 years or so. So we thought this is an interesting question, and using this database I presented to you just before. And this is what we did. So we have basically 3 groups. We divided up all the people with having an eating disorder from 0 to 7 years, 7 to 14 years, or more than 14 years, based on the questionnaire data. We had valid data for about 400, 500 people. And here are the results. So you see here on the horizontal axis, before and after one segment of treatment, outpatients. And here you see a score on clinical severity. So you see the 3 groups. The long eating disorder group is in green. And what we found was that there was in all groups a decrease in symptoms. There were still symptoms after 4 months, but there was a decrease in symptoms. But the duration of illness did not have any impact on it at all. So what we found in this study is that illness duration was not telling you something about how someone is doing in treatment. So this is obviously one of the many studies that have been published outside the field, but we thought it quite interesting that it came up. And it also taps into clinical reality. For the patients, we feel it's an important finding because it basically means it's never too late to start or to restart treatment if you have an eating disorder already for a long time. For clinicians as well, it could be a relevant message because it means that illness duration on its own should never be a parameter to plan treatment or to deprioritize people in some way. So this way, this is an example of how we can use research in clinical practice. So the third line of work we do is on self-help interventions. This is a project we did among people on our wait list. Fortunately, depending on like the time and how urgent it is, people often have to wait for treatments. And we did a study and provided psychoeducational materials to people on the wait list. And then we studied to what extent this was helpful to already reduce a bit their eating disorder symptoms. And we found some positive findings. It did not cure them. They still got treatments. But for now as well, given that it seems to work, we offer these resources as well to people for whom it is relevant. We're currently also starting another study, which is a little bit more interactive materials, more focusing on motivation and ambivalence, but that's still ongoing. But this work is on the waitlist participants. The last thing I want to present is on training of health professionals. The reality is, like, as I said, there's a lack of services for people with eating disorders. People have to wait for a long time. Certain regions are far from, let's say, Montreal. If you live in Abitibi or in Chicoutimi, it's not easy to get services because it's far away from here. We know actually from research that about only 1 out of 4 people with eating disorders actually do get evidence-informed treatment. So that is actually quite low. And again, there's a lot of stigma as well. And often people don't feel comfortable without proper training. So for that reason, our program basically offers a 3-tier focus in training for health professionals. We do regularly some webinars. That's the level I hear you see in yellow. These are free available. We organize them through Zoom. Our next one actually is in June. We have a more detailed program, the ECHO program, Echo Mental, which is according to a standardized educational format, which is a little bit more intensive. And the most intensive knowledge training program is people get 12 hours of lecturing, and as well they get clinical supervision from our clinicians with the idea as well that people could follow cases in the community if they're not too severe. So for us it's good as well because it could impact our wait list. And for patients it's good because then they don't have to travel all that far if you live so far from the Douglas. So it has as well a lot of advantages, this program. So we do research around that too. So we're testing the different trainings on satisfaction for patients and for clinicians. We measure clinical competence, factors of success of implementation, impacts, and this, we haven't done that part yet, but we're working on it. Also impacts of training on wait lists and cost effectiveness as well. This is something we're going to start over the summer as well, doing using some administrative data as well. So to summarize my talk, research, how is it integrated in clinical care? This is our clinical model. Patients are recruited through the programs to take part in, let's say, imaging or molecular studies. They provide data that allows us to answer questions on predictors of response. And at the same time, like when we have interesting data, we also try to integrate it as well in our services to make our treatments better. Our self-help work as well, we've done some work on testing out the self-help, and now the self-help can be used as well among waitlisted participants. And the same with training. We use the evidence-based information to train community professionals, And by studying these trainings, we always try to make them better. Lastly, I would like to reflect some of my own thoughts, and I would like to emphasize what you see here is there's no science behind it. These are really just my own thoughts. What makes clinical research integration work? I would say really co-production. I mentioned the question on duration of illness, which was born during peer supervision meetings, and I can give other examples too. I think really having questions that come from people who see also a lot of patients and not only from researchers. Having a collaborative environment, so meaning everybody kind of contributes to research a bit, whether it's even by filling in clinical rating forms and so on, recruiting patients. So to really be collaborative. And it's the same for our research assistants. They're hired to do research, but sometimes they also assist in other things, whatever is appropriate. So for example, organizing trainings. Visibility, I think, is a key factor. As a clinician, it's often very easy to forget about research. And even by myself, when I'm with a patient, I sometimes just forgot my research and I forgot to ask them to recruit them. So visibility is important, not only posters in waiting rooms, but also physical presence, like in terms of having research space or anything really making it visible. So it's an easy reminder. And at the same time as well, integrating research at any stage of the patient treatments. Our program has a bit of a culture that it's already from the start, that people are used to be asked for research, which I think is an advantage. And also share your findings. We do common teachings with research and clinicians, sharing results as well, giving them back to the team. I often give an update in our clinical team meetings about whether it's a publication or something that I've looked at in our stats or whatever. And I think it keeps people as well really engaged as well in a mutual way. So again, these are just some reflections, and that was the end of my talk, and I will be happy to answer any questions you have.
I have two questions
Yes.
that are kind of related. So I was wondering if in like, let's say, like the 20 last years,
Yeah.
you notice like the difference in the number of service users.
It's a good question, actually. So actually, recently it's perfect time because I just communicated this not too long ago to my two colleagues in my team. So with COVID, there was like a very big increase as well. Then it went down. It's now fairly, stable. It's still too high, let's say, like in terms of wait lists, but yeah, there's still a substantial number of people on the wait list. Yeah.
Do you see like any kind of correlation between the number of service users and like fashion trends?
It's an interesting question. It's something on my list I would love to look at as well, even like, because the whole measurement is said it's not to say something that the measurement-based practice is already a culture in our program for a very long time. It's something I think interesting also to look over time. If you go more than, let's say, only the 5 years, I think to study that well, you really need to look at a very large period of time, let's say, whether it's like, when social media came up, or like even what is, kind of the perfect models, let's say, in that way, like, there's different trends there too. So I think it's very interesting, but I think it needs to be studied on a very large scale basis to be informative. It's a very good question. Yes.
I have a question. You mentioned that the duration of illness not being a predictor of treatment response. Do you find that finding is specific to eating disorders? Does it translate to other mental disorders? If it doesn't, explain.
Question. I'm not sure actually. I know in depression, for example, there's more known, for example, in terms of like, when you have more episodes, you're more likely to relapse, for example. But I'm not aware of other fields that much how that translates to duration of illness. Yeah.
Okay.
Maybe I have limited my search in the disorders.
You know why it would be that it wouldn't influence? Like, I mean, I understand why it came up during the meeting because it's not intuitive.
Yeah.
Like, sure.
Yeah, I mean, there could be different, I think, explanations in terms of like the severity might also like fluctuate. We sometimes also know that recovery can be sometimes just unpredictable in a way that there's no clear predictors as well in the fields. And sometimes it's, there can be certain changes, like a combination of different factors that might drive like whether or not someone would respond as well. I think as well, duration of the illness maybe yeah, there could be also like, some biological changes as well that are, like stable or unstable, and yeah, so there's not even clear explanation. Yes.
Hi, it's more of a comment.
Yeah.
So I'm manager of youth mental health. at
Yes.
CEYMH-CESMJ.
Yeah.
So I want to say how the collaboration.
Yes, yeah.
Is amazing.
Mhm.
You were talking about, the training that you did.
Yes, yeah, I'm working a lot with your site too, so.
Exactly,
yes.
exactly.
Yeah.
So it's been working well.
Yeah,
But I'd like
absolutely.
to name how, offering this, opportunity to consult
Yeah,
is key, because
Yeah.
when you do get the training, 1 or twice a
Mhm.
year,
yeah,
then if they don't have a client right away, in their
Yeah.
caseload to apply, these new strategies,
Yeah.
then of course you lose it and you forget.
absolutely.
So then when they do get a client, then
Yeah,
it's,
yeah,
sort of features,
yeah.
then it gets, messy.
Mm.
So knowing that you're also, very sorry, one phone call away, this is very reassuring,
Yeah,
and that's, so, spoke about, I'm not sure how broadcast it is, but this is, a key.
Yeah,
Key,
yeah, and I also referring, actually, I just looked very, like a few days ago on like the number of referrals to each site, and I also see that your site also takes on more cases as well, which is
Yeah.
also we're also very grateful for the collaboration as
Yes,
well.
yes,
Yeah.
thank you.
So I know personally when I think about eating disorder, like the stereotype
Mhm.
patient is like a teenage girl or a young woman.
Mhm.
I was wondering if you see sometimes like eating disorder developing in like adulthood and
Mhm.
even like older adults. Like,
Yeah, absolutely. We often think about the stereotype like that it's only like young girls, and statistically speaking, a lot of like in their teenage years or early 20s, this is the time that often eating disorders develop. But definitely, it also I don't know the specific percentage by heart, but I do know there's various people who have like treatment in our program whose eating disorder only start later, like midlife or after certain traumatic events. And then when you ask about the history, there's really nothing to detect that was there almost. I find it also very interesting as well. And that's also, potentially could be other research as well. But it does happen. And the same as well, males could get eating disorders too. Even though it's more common in females, but still males could get it too. And so any age, any gender, any sex, and also any ethnicity or sex as well.
So I imagine to be admitted into the program
Yeah.
here, you have to be 18. I guess anybody under 18, they go through the children.
Yeah, so it's a good question. So for 18 and up, it's suprarregional, so anyone. And then for between 16 and 18, it depends where you live, like because it's like the way that the
Right.
CS is organized. Pediatric programs in Montreal or like the Montreal Children or 16. We also work a lot together, let's say when people need more help, and then for transitional care as well to have, proper transfer. That's yeah, absolutely. And Stearns as well as the long
Right.
like this as well as place. Yes.
2 questions. The first is, do you see a lot of postpartum eating disorders?
Mhm.
Like as people experience physical change?
Yes. Not that much. Sometimes we get people who are like pregnant, for example, and have eating disorder. We do see sometimes with PC as well, given that eating disorders, can happen at any age. We see, for example, young women who just get their baby and are struggling by balancing like family life and like eating disorders. It's something we have not systematically studied, but it does happen too, indeed. Yes. Yeah.
And then I guess maybe just to ask you to speculate a little bit and
Yes.
connected to Fiona's
Yeah.
question on like the GLP-1s and how's that changed
Yes.
like kind of celebrity. And I wonder
Yeah.
if you see like any interaction there, or if this is
Mhm.
also an opportunity in a
Yeah.
sense to understand how like a big societal shift
Mhm.
towards a different body type
Yeah.
more easily accessible.
Yeah, it's an interesting question. We have not systematically studied it. We often get referrals to our program and say people are on GLP medications, and then it depends as well on the clinical situation. But it is an interesting thing to study indeed, and almost you need on this longer time frame, because if you look over time, for the lack of better wording, there's sometimes trends in things as well. And I'm not saying I don't want to, because for many people, GLP medication for certain disorders, it's very, it's important. I think my own opinion with the GLP medication is like, it could sometimes put emphasis even more on like, okay, you need to have a certain body type, let's say. Yeah. Yes.
I just have a quick question, because you mentioned like genetics and epigenetics
Yes.
of like
Mhm.
anorexia and ARFID. Do you also look at like other eating disorders as well in general, like
Yeah, absolutely.
bulimia
I
or
mean,
anything like that?
yeah, in our program, we see a lot of people with anorexia nervosa, bulimia nervosa, OSFET, which are people who do not fit into any of the traditional categories, are fit as well. But yes, absolutely. Like for the neurobiological research at the moment, we're looking only more at anorexia and are fit. But I know there've been in the past work on bulimia and also something that's is definitely worth studying. The same with OSFET too.
I also just wanted to ask, I'm curious on like how you measure like recovery, because
Mhm.
like body types, like they might be physically
Mhm.
recovered, but
Yeah.
like how do you measure
Yeah.
like the
Yeah.
mental like
Yeah, that's big.
residue?
Yeah, it's a big question because there are no formal, besides from, let's say, not meeting the criteria anymore in the DSM, there's no proper definition of recovery. We're looking at more for the research, more in terms of like, reduction in disorder symptoms, improvement in, let's say, quality of life, less functional impairments. Clinically as well, there's a lot of differences as well. Like I think, a key core symptom of almost any eating disorder, except for ARFID, is a fear of gaining weight, as well as obsessions around food shape and weight. So you can also think about that, like to what extent is someone still very preoccupied, let's say, or to what extent does it take, let's say, like, the amount of time it spends on a day, for example. So there is not a proper definition, but in research, we usually just quantify